Welcome everybody to the World Patient Safety Day 2021 panel discussion. My name's Pip Brennan, Executive Director of the Health Consumers Council, which is an independent not-for-profit organisation. And I'm excited. This is a partnership event with the Australian Health Practitioner Regulation Agency. It was a conversation that we've been having for quite some time about doing something. And so here we are. The theme for this year, as we know, is maternal health. So I just wanted to take a moment and pause and acknowledge the traditional owners of the lands on which we're meeting. Where I am is Borlu in Perth, beautiful Noongar Butcher. So I would like to pause to pay respects to the Aboriginal elders, past and present. I'd like to acknowledge the Aboriginal leaders that we are blessed with. We have one on our discussion today. And I just really wanted to, as a Wodgala, as a white Australian, just acknowledge that that the land was never ceded, and it always was and always will be Aboriginal land. So today, as mentioned, we have a panel discussion. So this is going to be a somewhat of an interactive discussion. So please do feel free to post your questions in the chat, and we'll be monitoring that. We did ask you if you had any questions. We've had a couple come through the registration process, but as panel chair, I get to ask the first question. So lucky me. And I wanted to just very quickly introduce our panelists. So we have Professor Rhonda Marriott, who I'm going to talk to first up. So she's a very key Aboriginal maternity researcher who's done incredible work around advancing the cause of birthing on country. What I'll do is I'll actually introduce each panelist before I speak to them. So because I think just technically it's a bit hard to spotlight too many people. And I can see Rhonda and I are beautifully spotlit. And so Rhonda, as you know, I wanted to start with you because this is a really special day for you as a mother, your son's birthday, and you won't be able to be with us for the whole conversation. So we're very, very keen to hear from you. So I wanted to ask you your question first. So Rhonda, you've been doing really important work through Murdoch University's. It's a NACURA research centre, and it's really about championing and highlighting the importance of birthing on country. And I wondered if you could share a bit more about the work you've been doing.
Thanks very much, Pip, and good morning, everyone. I'd like to say hello to you all and to also wish you a wonderful day today, and to acknowledge that I am also on Wodjuk Budja, and to pay my respects to elders past, present and emerging, and to say in the season of Julba, this is just the most magnificent day. They forecast a little bit of rain, and I'm hoping that the sunshine holds out for us all because it's really a perfect day and the wildflowers are stunning at this time of the year. And Pip, thank you for acknowledging my son's birthday 50 years ago, which was a Friday. I was at South Perth, in the South Perth Maternity Hospital, giving birth to my son. So it's really quite amazing to think 50 years on, I'm sitting here talking to you about a research centre. And Pip, our research centre is, as you said, NACURA, and it means mothers rising or the sun travelling across the sky, and it's meant to, and we're honoured that Auntie Marie Taylor gifted us the name because it's meant to signify the journey of mothers through their children's lifetimes. And I think that's really apt for us and the work that we do, but apt for me to be able to share some of that work that we do. And our work does focus around the maternal and newborn space, but in particularly, we've been interested in the experience of women who are Aboriginal women who are birthing on this beautiful country of ours, on Wodjuk Budja, and highlighting their experiences and their stories. And a number of you on the panel today have been part of our Birthing on Noongar Budja journey, which started, if I can, Pip, in 2012, when a number of us went to a Birthing on Country symposium that was held in Alice Springs to talk about the needs of women and the birthing on country needs for women, particularly women who are living, further from maternity services than others. So, we might say that they're remote. They would say that they're living on homelands. And I came away from that thinking, but what about the women who are living in a city, who we would consider to be urban residing? What about their experiences? They are close to the big maternity centres. Do they have a culturally safe experience? They are birthing on their own country, particularly if they are Noongar women. So we set about a birthing on Noongar Butcher, we called it, research project, and we interviewed 74 Aboriginal women. 11 of those women were elders, and the rest, we had 39 of those women had a birth within the previous 5 years experience, 5 years rather. And it was really interesting talking to them, because many of them said that they had a good experience, they had a known midwife, they had that continuity of care, and they felt respected, and they felt that people asked them what it was that they wanted. Was there anything special that they wanted culturally to support their birth? But unfortunately, there was still a large number of those women who said, no, it was the worst experience of their life. They were treated badly, they were treated with disrespect, that the midwives didn't have any high expectations, that they would have questions, they might even have a birth plan, or they might, want to know a little bit about what was happening to them, or that they might want family members present. So, I think we've still got some way to go, unfortunately, for our women to have a really positive experience. And I know that there's a lot of fantastic work that's happening right across our state, with a focus that the Minister has put on ensuring that women have that culturally safe experience during birthing, because we know if you have a good birth, you have a good experience and start as a parent, if you're supported well by good health professionals who have a respectful relationship with you and a genuine relationship with you, that you're more likely to go to them and seek help with your child as they're growing developmentally, if you need assistance. So we know that that's all so important, but we've still got some way to go. And I don't know that if I really answered your question, Pip.
I think it did. I think, I guess I just wanted to flag too, like, I think, the project that you've been working on, I remember going to a roundtable discussion on, and then, sometimes what happens is you don't get to hear much about what happens next. I guess I'm curious to understand how your project intersects with services available for women. Do you kind of are you directly connected with Aboriginal programs, and what are they and where are they at?
Yeah, so we have the most amazing Aboriginal maternity group practice programs, one that's been established for a long, long time. Jari Yorgas in Armidale, Kelmscott. It's, part of the health service. It's, financially supported and funded, and, Aboriginal women are able to go there and have that continuity of care antenatally and postnatally. And the midwives can also provide the support during the birth. So that's a fantastic program. The Mortbajari Maya program, which is now part of the St John of God group in Midland, it is a program that is continuing, and the Aboriginal women continue to want to experience and have that support. Many women were birthing at Swan Districts, and now they're birthing at St John's in Midland, and they're still able to have that support. We have some fantastic programs across across the state in the wheat belt, support for women in the Kimberley, and we have a fantastic program that's beginning in Bunbury through the Southwest Aboriginal Medical Service, being able to provide that continuity of care. And while it's not necessarily called an Aboriginal maternity group practice, they're still applying those principles. And from the recommendations that we made to the Minister and the Minister's support, we know that now that our oldest and still premier maternity service, the Edward Memorial Service, is establishing an Aboriginal maternity group practice as part of their service. So women who are high risk, who are identified to have that support and go there, are able to have that experience. And we're increasing the number of Aboriginal midwives, but we've still got some way to go in being able to attract and retain the number of Aboriginal midwives we know that we need. And all of the women in the project said to us, we need Aboriginal women who are providing that services. Traditionally, we had our families and our traditional midwives. We want to see Aboriginal women who are midwives in our services. So we're getting there.
Yeah.
The other thing I wanted to just quickly share with you, Pip, when you talked about the outcomes out of our project, was that, and I think you did come to our symposium, our Birthing on Noongar Butcher symposium on the lovely birth of Ron Swan on the Derbyl Yerrigan. And out of that, we had a number of posters that the elders were happy to share their birthing stories. And from that, Auntie Doreen Nelson said to us all, because it was because of Her We Can theme of NAIDOC that year, we have to make this a legacy. This has to be a book. And so we have Trunk Wandjini,
Beautiful.
which is a beautiful book, which has been edited by Auntie Doreen Nelson and myself and Tracy Ribel. And that is the beautiful Cubbly Cuddigan painting that's been painted by Valerie Archie, who is an Aboriginal midwife. And that graces the cover of our book. And we have 12 elders and senior women who shared their birthing stories. They're very personal stories with us in that book. And that's been just the most beautiful outcome, because it is a living outcome with a lot of information in there for midwives about how best to support Aboriginal women. I think that's fantastic.
It's beautiful. And I'm thinking that one of the things I've got in my head is there like a sort of a place we can get in touch with updates about the project, get hold of that kind of thing?
Yes, absolutely. So I'll send you the link to our website that will that talks about the book and talks about the recommendations, our report that we provided to the Minister, and talks about the things that are happening. We're very, very excited that one of the recommendations that we had was to see an Aboriginal nurse appointed as the principal Aboriginal nursing and midwifery advisor in the nursing and midwifery office, and her name is Deborah Jacobs, and she's just fantastic. We're really very, very excited about that. And I believe we're still the only state that can claim that we have a principal Aboriginal nursing and midwifery advisor.
That's amazing. I was I'm not sure how much longer I've got you, because I know you've got to go, but I was curious to know too about there is a women's experiences and maternity services that's a validated tool for women's experiences of maternity care. Is that something that you're familiar with, and is that something that you feel captures the experience of Aboriginal women?
I'm not familiar with it, Pip, so it'd be really nice if you could send me the link to it to have a look at it. I hope it does share, the experiences, the experiences, the sad experiences that we heard and the joyous experiences that we heard are not confined to Aboriginal women. And one of the things that we know is that if we get it right for Aboriginal women, we get it right for all women. And all women have the right to have the birth experience that they're hoping for. And it doesn't always happen, things can go wrong. Unexpected things can happen. But if we're supported, if women are supported through that process, it can still be the best experience possible.
Sorry, you go. You finish. Sorry.
No, sorry. I was just going to say, that's incredibly important, because even for women whose babies are born sleeping, as we call it, they still can have a positive experience. They can still have that connection with their baby. And, the worst experience can become a good memory.
I do have a question from Bridget Blackwell from the chat, and she said, what are the big barriers to birthing on country from the system, and how much does other people's fear play out, i.e. what happens if something goes wrong?
Okay, I think one of the biggest barriers to birthing on country in the system is the system itself. The system, it's very bureaucratized, and the system is the people in the system. But, people in the system can still rely on rules and reasons for, things not being supported. So, I think biggest barrier is ourselves as midwives, being open to being able to provide that support, outside our own comfort zone quite often, and being brave enough to, this is not my birth, this is not my experience. I need to be there. It's called woman-centered care. And that's what we need to provide. We need to go back to remembering this is woman-centered care, it's family-centered care. So unfortunately, I think that those are still the biggest barriers. We can have all the rules and all the changes. Essentially, it's that midwife who's providing that care, that doctor who's providing that care. And everybody needs to be on board with that. And, quite often, I think the second part of the question was around fear and how does that play out. Families can often be fearful that their experience is not going to be the best, or that maybe they are high risk and, they're fearful of what might be the outcome. It's about being calm and being centered, and being there in the moment with that family, and being able to do that for them, and set aside your own fears, perhaps, or your own lack of knowledge.
I've got a question here from Jane about what are the barriers to Aboriginal midwife workforce, building that?
Well, I guess there are a number of barriers. One is, the pathways into midwifery programs, and we're still working on some of those, and unfortunately we've lost our direct entry midwifery programs. So it can be a long journey if you need to become a registered nurse and then do midwifery as a postgraduate program. So there are still some of those educational issues that we're working through. Not all women want to be a midwife. Some want to be doulas. Some want to be enrolled nurses, but working in the maternity sector. So, it's about supporting whatever entry pathway women want to have. But one of the main barriers, I think, is sometimes the inflexibility of our work setting. So, being able to have responses to workforce in a way that maybe meets their family needs and their obligations. So, having part-time, having casualisation that still allows career pathways, so that it doesn't become a dead-end area that people are forgotten about in terms of promotion. And being able to support, we still have racism, unfortunately, in our health sector, and being able to support Aboriginal women who choose this pathway, in an environment that has a zero tolerance for racism.
Totally. There's just one more question, because I know you do need to go, so I'm just going to, one more question. And it's from Brittany. It says, will a program similar to Jacomea be introduced to help women in rural and remote areas?
Oh, yes, I hope so. And I know Kate Reynolds is on the call as well. And Kate and I think so similarly. And I think I saw Tracy Martin was on the call as well. we all think similarly. We want Aboriginal doulas. It's got to be a real pathway. And yes, Jackamere is just amazing. And I think, you know, putting it into a film has exposed more people to the possibilities, and has shown how, you know, it's incredibly important to have that continuity of culture and that support, that real cultural support. So yes, we absolutely are working towards that. And yes, we are committed to it. So we do want to have that across the state. And Kate, I'm sorry I'm speaking for you, but I can definitely say that Kate Reynolds is there 100% championing this.
Thank you so much, Rhonda. So I think at this stage we might need to farewell you so you can get off to your son's birthday. So happy birthday to him. Thank you so much for your time.
Thank you, and I wish all of you the best, and best wishes as well for the remainder of the panel. It's been really lovely speaking with you all, and thank you, Pip, for the invitation. So it was really lovely.
And I'll share the links that you're going to share with me. I'll make sure to get them to people that attend.
Okay. Thank you. Bye-bye all. Bye.
So I'm going to move now on to Karen Banks. So Karen Banks is is my partner in crime in this event, and is the WA State Manager for the Australian Health Practitioner Regulation Agency. So Karen and I have been meeting with some regularity, and we thought we would like to do something together. We thought World Patient Safety Day seemed like the ideal opportunity. And so I do want to thank you, Karen, for your partnership and inspiration, and also your courage, because I think we sometimes feel that people in statutory bodies don't always, you know, want to do stuff as juicy and community focused as this. So I do appreciate that. And I was wanting to ask you, like, as Ahpra WA State Manager, what are some of the maternity care issues you see coming through in the notifications to your agency, and are there any key themes in that?
Thanks, Pip. Hi, everybody. I think we have two main themes. Pip, outside of that, what we're seeing an increase in notifications. So in the regulator, we talk about notifications instead of complaints to differentiate the idea that it's not complaints management, it's that much more pointy end of the risk triangle that we're looking into. And we're seeing two real groups of notifications coming through these days, and in increasing numbers. So in maternity and obstetrics, we're seeing a real group of things around expectation. So a group of notifications that we can think about expectation. So it fits with the description that Rhonda gave about the importance of, I got distracted by the pop-up box, about women-centred care and family-centred care. And so this notion of unmanaged expectations. And I think part of the building of the contract between a woman who's getting ready to birth and her treating team, and, you know, talk about the treating team, you know, her care team, her midwives, her everybody who's involved in that space, and they don't seem to be merging as often as we'd like to see, because that's why we're seeing an increase in that space. You know, we live in a really social media driven world. People have a picture of a beautiful experience, I don't think dissimilar to some of the things that we've just heard from Rhonda, but I do think that expectation is perhaps not communicated well or managed well in every occasion, and that would be explained why we're seeing more and more of those kind of notifications about the expectation that we didn't follow my plan. You know, I had a very clear picture of what I wanted and I didn't have that. So, and that is one whole cohort of the things that somebody wanted or thought they would have or had thought they would have time for that they didn't. And then we see the other side of that, which is much more about inherent clinical risk. So things happen, you know, and, you know, we talk about different aspects. I can see Denise's question when we come to that. I can see we see a lot of clinical incident workups that perhaps are inherent risk that people felt that if care was managed these days, they wouldn't occur. And that's not necessarily the case. Sometimes it's the case, but it's not always the case. And so we have that. But when I think about the notification space, the reason that they make their way all the way to us is that they're unresolved. It may be that they were always going to occur and they were clinically expected at some stage. And if it was not this person, it would perhaps be the next person. But they regularly come to Ahpra because they're unresolved. We don't seem to be able to focus enough effort across our clinical practice yet to help people to move past what's occurred and to cope with it and deal with it, which is why they make their way to us, not necessarily because there was something wrong in the technical aspects of the care. And we see that more probably than when those very rare occasions when there was something technically wrong.
I was having a conversation with a colleague who is on the Community Advisory Council down at Fiona Stanley about a whole range of things, and she just was talking about the importance of thinking beyond clinical care to relational care. And I think that's something that, you know, we don't hear enough about. And I feel like that sort of captures a bit what you were saying in that last point, and the lack of resolution. Yeah,
I think so. That's it. You know, I talk glibly sometimes about, you know, if you want to say sorry, people will say to me, you know, they write to the board at some stage and says, "I'm sorry, Mrs. Smith. I'd like to apologise to Mrs. Smith." And I think, well, actually, if you'd have done that 18 months ago, we'd never be where we get to today. And so that's my number one thing that I say to people is, if you're sorry, tell your you know, your patient, your care provider, you know, just tell each other if you're sorry, and then work out how to repair and rebuild. I think that's it's the burden on everyone is much reduced if we can remove some of those barriers of fear to just being sorry.
Yeah, absolutely. I won't quite finish with it there, but I do want to bring in Rosie Keely, because I feel like it really follows on nicely, is the conversation around, you know, relational care, around saying sorry, around, you know, managing feedback in perhaps a more flexible way. And I had invited Rosie Keely from WA Country Health Services, just somebody who could speak a bit to the care opinion tool, and how that has, you know, just also, you know, with a bit of a focus on maternity and childcare. So, that's really what I was going to basically ask you, Rosie, is about, you know, what are some of the key stories you've seen come through care opinion, and, you know, how do you build on that conversation around, you know, relational care versus clinical care?
Thanks, Pip. And gosh, there's so much to say. Can I just go off track a little bit, because just what Karen has said has taken me back to when I worked at PMH a number of years ago. The power of sorry and what sorry can do is extraordinary. And if you don't mind, Pippa, it's a really quick story, but it really does emphasise, I think, what I can also talk a bit about around care opinion. But what had happened was this young man, 15-year-old boy, had a history of cardiac disease. He came into PMH, something went wrong, and there was fault, unfortunately, for us at the health service. Over a number of months, you know, conversations took place, and I mediated with the clinical staff and the family, and we ended up having a meeting in a room. It's set up not relationally, not at all, in a boardroom setting. I sat with the family, and the clinicians were on the other side of that room, and it was one of the most uncomfortable experiences personally I've ever had working in health. There was a lot of fear, a lot of anxiety, a lot of, Mum was sternly sitting there, very focused. Dad was crying a lot. The clinicians on the other side of the room were probably terrified, and in fact they were. And we reached a point in the conversation where I think there was about 30 or 40 seconds of nothing. That's a long time to sit in a room there were 8 of us in the room, including a chairperson. Nothing was said. So I had formed a relationship with Mum and Dad over the time that I'd been liaising with them, and felt comfortable doing this. And I just put my hand on the dad's arm, and I said, "We are so sorry for what happened." And honestly, I can feel it in my bones now. It changed the atmosphere in that room. Conversations took place. There was just, the stress was released. Sorry was said, it didn't matter where it came from. I know the power of sorry. I say sorry a lot, even when I probably don't need to. But yeah, I just wanted to share that with you because it was one of those moments. It was one of those stories. I've shared the story before where I go back to that and think that the power of sorry is amazing. And so I'll talk a little bit about Care Opinion. So we've had Care Opinion, the online platform at WAX, for about 6 years. I've been at WAX for 3 of those. And in that 3-year period that I've been there, you know, I've seen a significant shift and a real embracing of the platform. There was some original fear around what it meant. You know, this is very new and very scary, a public platform where patients and families can go on and share their story. Okay, moderated by you know, Care Opinion in Queensland, but still this is a very different way of providing feedback, and requires of the system itself to be much more relational, much more person-centered. We respond on that platform in ways that we would never do in a ministerial or a complaint, if you like, complaint response. In the 6 years that WAX has had Care Opinion, we've had 2,703 stories as of yesterday. Of that, 249 with the tags maternity and midwifery. So about 10% of the stories that we've received over that time relate to maternity and midwifery. And I think, you know, as a system, the evidence is very clear that, you know, these online mechanisms are becoming increasingly more popular. We'll see more of them. And I think, you know, activity is only going to increase and people will have the opportunity to provide their feedback that way. I just want to share a quote with you from Michael Greco, who's the CEO of Care Opinion, a wonderful man. And I think it really relates to what we've been saying around relational care. And he says that feedback is a relationship. It's one way that people receiving a service can express their care in return for those who provide it and for others who will use it. It's an expression of the values of equality and mutuality which lie at the heart of our health service. So we spread that message, we share that message, and I'm here today in Balladong Noongar country in Northern today. I travelled up this morning to talk to some staff this afternoon about providing compassionate and kind responses in all the feedback we receive. It really does make a huge difference to the experience of you know, the patient and the family, and equally for staff, being able to receive such positive feedback themselves. You know, you can go online and have a look and see what's said, and 66% of the stories that we receive currently across the system or across WAX are positive. So it's a fabulous mechanism. It's not just about for those people who aren't happy. There's a lot of very happy people, and we like to share those stories with staff. You know, it's about building resilience of staff and morale and those things. And of course, we receive the feedback, but you know, more importantly, what we want to do as a result of that feedback is make changes to improve. So can I share a story with you that we received? It's a maternity story, and we were provided 2 responses on the platform to this story, which was really great and really, you know, uses that, it really draws on what Michael Greco says about, you know, feedback's a relationship. It's not just, oh, we have to get this response out. It's about, you know, relationship building. And of course, across WAX in small communities, it's really important that patients and families trust their health service. So this is a story. It relates to Busselton, and the person posts, we attended the Busselton Health Campus antenatal day last month. It was a full day. It used to be over multiple days, but it's been changed due to COVID. I feel it would be better if it was spread over multiple days again, as I felt there was a lot of information to take in and absorb. I also feel a lot more could have been covered. I believe no mention was made of what happens if you ended up with an LUSCS and K Reynolds. I have no idea what that is. Would you like to inform us? I should have checked.
Lower uterine segment cesarean section.
Thank you so much, Naz. Thank you, sister. I also feel, she goes on to say, that there was not much information about intervention, just brief overviews. And also that she feels that, you know, I also feel like breastfeeding, taking the time to bring a baby home could have been covered more. I felt throughout this entire pregnancy, the system needs to change and better information needs to be available for new parents. Now, that is quite, you know, some would say a negative story, but you know, that's really valuable feedback. So we went back and we said, you know, thank you for this. I'm sorry that we couldn't fulfill your expectations. You know, these themes keep coming through, don't they? And I hope to make improvements from your comments. I'm happy to say that we're reviewing our classes. We've also found the session to be very long with the information required to give to our women and partners. We'll be making changes to our Saturday sessions and to the content, which will be reviewed. And then there's information about who to contact this person. And then a couple of weeks later, after we said we were going to make a change, we post on that platform that we have, which is fabulous. So again, that person and anyone else who's looking at Care Opinion can see that we've done that. So we again thanked the person for providing the feedback. I'm pleased to say that we've reformatted our classes, and then we now have weekly evening classes, and our weekend classes now have been divided into 2 sessions. This has enabled us to reduce the numbers attending and the format of the classes to cover subjects appropriately, including unexpected outcomes, assisted birth and caesarean. Within this format, we cover expectations when going home with a new baby, and we'll continue to evaluate what we've done. So, you know, that's just one of many of the couple of hundred odd stories around maternity that we've had that, you know, are demonstrating to patients and families, you know, that we are adaptable and flexible, and you know, we want to work with patients and families in designing care that works for them. Sorry, I feel like I've been talking forever.
Well, I thank you so much for that, Rosie. I just wanted to go back to Karen, to you for a moment, because I was really interested. You know, you sort of highlighted, you know, if only they'd said sorry instead of, you know, waiting for all this time and then writing to the board to say, oh, tell Mrs. Smith I'm really sorry. And I wondered, you know, what are the opportunities in the role that Ahpra may have around training, and also, of course, that connection between Ahpra and the Health and Disability Complaints Service Office, because, you know, with Ahpra it's an individual practitioner, with HADSCO or Health and Disability Complaints Service Office it's a bit more system based. But is there a bit of a referral back and forth, and do you sort of collaborate around training? What does that look like? So
we don't provide training, of course, at this, but we are having a really good think about how we could provide some better information and guidance that lets people understand what we're seeing in the regulation space, because if you understand what we're seeing, then you can prevent, you know, and that build your own process around education. And I think we do talk to HADSCO every week in WA. So as the discussion, every case, so it's a requirement of the national law that every case has a consideration between both of us, where we decide who's best placed to investigate that. Our intention is to minimise how many investigations occur around incidents, and so we have a discussion about who's best to action that, and depending on the characteristics of that situation. So, and often depends what people are looking for. So the Health Consumers Council has advocacy workers. We have HADSCO who have some space in mediation as well. Ahpra does, and the boards don't provide that. We hear a lot of people, so in a private practice and space, we hear a lot about, I would like a refund. My expectations weren't met, those kind of things. We don't offer those kind of services. We don't offer mediation. We don't seek refunds. We encourage other routes to resolution, which is those conversations for those ones, and trying to really focus our attention on where things have actually gone wrong, from a technical care component for practitioners, where it's a clear skill deficit. Although I think there's definite value in the discussion about knowledge and skill deficit, where the care perhaps was not technically wrong, but emotionally wrong. And that's a different kind of knowledge and skill.
It's interesting. There's a comment that's just come in through. I'll just read that part of it at the end that I think really speaks to that. It's a quote from Kit Singer from 2012, one of the many books she's written. But it says the last bit is, when birth is insensitively managed, clock watched, and interventionist, it can exacerbate existing trauma and may be perceived as violence. And so that gets back to that relational care. And I wonder, is it appropriate for me to just mention the work that Ahpra and the Australian Commission on Safety and Quality in Healthcare are doing at the moment around reviewing complaints processes?
Yeah, so we're working around, so there's a lot of people in the health complaints space at service level, at individual level, at regulation level. So we're doing a bit of work with the Commission around trying to make that more easily accessible. There's a lot of negative experience for practitioners as well as notifiers once you're in the regulation space, if you find you're in the wrong space, to help you get a resolution. And so we're trying to just do some work about the right complaints and notifications to the right doors amongst all of the partners, so that people can get that resolution more quickly if that's what they need.
Thanks so much for that, Karen. Lesley, I know you've asked a question, and I'm going to hold that thought because I haven't forgotten it. But what I thought I might go to next, because, one of the things we've talked about is choices. And Kate, I wanted to bring you in the conversation. I mean, people have already been talking about, Kate, because you have been such an important advocate for change for women in all sorts of ways. And we've been very lucky to be able to work together on the My Baby WA app, which, is really that idea to, I guess, we talked a little bit about, Rosie was talking about the example on Care Opinion where they're sort of getting quite a lot of information, and also that idea of being able to make informed choices. So I just wanted to ask you a little bit about your reflections around the My Baby WA app and why you wanted to be involved.
The My Baby WA app, the original thought around it was, our first issue is that women don't know what care options are available to them in their local area, and what was a quick and easy way to help them to find out what their options are. Part of that problem is that also the generalist GPs, and often, a woman's first pregnancy visit might be to a general GP, is that the GPs were telling us they also don't know what care options are available in the local area or the the area where the women are living, so they tended just to refer to either someone they'd worked with before, or their default was to the King Edward Clinic, or so we really wanted to make it easy for women to determine as soon as they are pregnant what their local care options were. So that's sort of where it started at and evolved from there. And certainly as an initiative of King Edward, the WA or their book, My Pregnancy, I always get the title wrong, Pregnancy, Birth and Your Baby. It's 110 pages long. It's a big book to cart around and refer to. We did generalise that for the rest of WA Health, so that all the health services, maternity services, could use that book as a reference source for their consumers. So we converted the contents of that booklet into the app to make it a little bit more user-friendly. We know that the maternity cohort are really keen for digital access and instant access. My kids Google everything. Every 5 seconds of the day, they get an answer to what they need to know almost instantly. We don't want Dr. Google to be the choice for learning about local maternity care options and evidence-based care. So we are really mindful of trying to keep the information up to date and relevant, and also put a schedule of care in there, to make it easy for women. What do I have to do at my first visit? When do I get these blood tests? When do I have to have my vaccinations? When do we talk about my care plan? So adding in a timeline so that people know what the usual expectations for an antenatal schedule of care is, all within the app. Obviously, it's not perfect, but version 2 is out. So we're very open to hear your feedback so we can improve it for our next version as well. But you know, the demand for the app has demonstrated that this is how women and families want to receive information. We're still having up to 80,000 interactions a day through the app. So that might be me thinking, what information have we got about morning sickness, and going in and out of a few different chapters. But there's really high demand for it, and we know that's how women want to receive information, and it's certainly much easier for us to update it across the state in one place than trying to keep 31 maternity hospitals making sure that women have access to, you know, standardised information about their care options and a standardised evidence-based information about all of that, all of those brochures. And it's just overwhelming. It's overwhelming for us as clinicians. So I can't imagine what it's like for women. So trying to keep it simple and relevant to where you are in your pregnancy or your journey, rather than having the whole book flicking through trying to figure out where you're up to and what you do need to know about. Did I answer your question, Pip, or have I gotten distracted again?
No, that was great. Yeah. Yes, I think that interesting, that conversation with the GP. Congratulations, you're pregnant. Which obstetrician would you like? Or do you have private health insurance? Which obstetrician would you like? Hasn't changed as much as we would like, but let's hope that
the same for women don't know, you know, where can I have a water birth, or who is supportive of VBAC? If I did want to have a breech vaginal birth, you know, who would I go to, and how do I find out about, you know, a supportive caregiver for that? So that's some of that detail is not quite there yet, but we're hoping to have that in the second version as well.
There's a question too from Denise Hind. It's, you know, I think a question we would all love the answer to, but how can access to a full range of maternity options not be a postcode lottery? And I think that's the big question.
It is a big question, and it shouldn't be postcode derived. If there isn't a service in your local area offering the option that is your preference, then you should be able to cross boundaries. And I'm sure, you know, it may require individual negotiation, but if you're living in an area that's not providing a service that you need, you should be able to cross a boundary to get to that service. And your midwife or your local care provider should be able to help you transverse any of those barriers. And certainly within the app, we have, I don't think we've got the detail in yet, but certainly for the privately practicing midwives, we also want to have those options in there. And we've certainly included all the private hospitals because, you know, lots of women choose to have private hospital care. So you need to know how to access those services, and you may want to choose between different services depending, or different providers depending what services that they provide. So we hope to have all of those in the next version, so to make those decisions easy and early.
Yeah, and I thought that the question, that was also a question that Denise put through when she registered about, you know, it's conservatively estimated that 1 in 3 women today experience birth as a traumatic event, you know, and that can obviously cause post-traumatic stress disorder. Yet there's no campaign in WA to address this, and research shows continuity by a known midwife can reduce trauma and many other negative birth outcomes. But again, there's no universal access. And, you know, what do people think about how to address these two issues? I know I was thinking, Kate, and I know that you, Lesley, would also like to take that. So I'll come to you in a minute. Hang there, Lesley, but I was going to start with you, Kate.
Two very big questions. And Tracy Martin, in the Principal Midwifery Advisor role, recently did a snapshot audit, and it looks to be about 7.5% of women birthing in the public system have access to continuity midwifery carer. Historically, public maternity services, you don't generally have access to continuity of carer. You might see a different midwife, a different doctor, a different level of doctor through the antenatal clinics, and certainly for your labour and birth care, you might be lucky to meet any of those carers again. We know that continuity, whether it's by midwifery or by midwives or an obstetrician, do improve outcomes and you know, have happier mums and families associated with that. But I think one of the biggest concerns for me across my career is that our language is just so risk and fear-based, and it's almost like some women are telling their war stories almost as a badge of honour, and everywhere you look you only hear the horror stories, you don't hear the great stories, and trying to change our language around risk and referring to chance instead, and flipping, instead of only talking about the negative side, focusing on the positive. You know, you have an 85% chance of a vaginal birth if you labour spontaneously versus, you've got a really high risk of having a repeat emergency caesarean section. Just changing how we talk, I think will go a long way to reducing that fear, giving women access to positive birthing stories. And certainly as a silver lining to COVID, in our health service, we had to jump to telehealth options, which we were providing because not all of our women in country can get to a health service. We did jump very quickly to offering it is the Hypnobirthing Australia program, but we call it the Positive Birth because for some reason everyone associates hypnobirthing with hippie speak. And we've run it very successfully via telehealth. 75% of the women that we surveyed actually preferred it to be delivered via telehealth because they can sit in their pajamas with the dog on the lounge and their FIFO partner can be dialing in from the mine site at the same time. And it is really around, any birth can be a positive birth, no matter what the outcome, and just empowering women and their partners with a really strong toolkit to help them navigate the twists and turns that pregnancies and births can take, so that no matter how they do end up giving birth, they've got the tools and they felt like, it was all around their choices. They felt empowered to make the decisions for themselves. And that's certainly the feedback that we are getting from the women is that, yes, things didn't quite go to plan, but I felt really comfortable and I felt in control and I felt respected and I made those choices and I'm happy with my outcome. And that can only go a long way to improving, their own self-worth and their own happiness, and their bonding with their baby and their bonding with their partners. And the feedback that we're getting from the partners is also really great, that they actually felt useful, they felt actively involved in the pregnancy and the labour and birth. They felt they had the tools to support their partners, and that, they didn't feel like a bystander in the episode, and that has also really improved their bonding with their partner and their child. There was one dad in particular who, that was their fourth birth, and they had done the positive birthing course, and he reflected that he didn't feel connected to his other children at all because of the birth experience, and that he didn't feel like an active participant. And that having that opportunity the fourth time, he actually did feel a little bit of guilt that he missed out for the other three, that he felt actively involved, so much more connected, far less fearful, and that it really had a strong impact on his role as a father. So I think giving women access to those tools early in the pregnancy and those sorts of courses will go a long way to removing that fear and putting the power back in the women of the hands, regardless of the risks that we're talking about and scaring women with, to get them to cooperate with, policies that we think we're bound to. And certainly, obviously, trying to improve that access to continuity of care models, which we are working hard to do. It doesn't seem like it, but certainly in our health service, we have 8 midwifery, we have 18 maternity sites, we have 8 midwifery group practices now. We've got another 4 coming on very shortly. So, we do have it in the majority, and we're hoping that all of the metro health service public health service providers have midwifery group practices, not in every hospital, but certainly they do have them. So we are working hard, and hopefully by the time I retire, we'll have one in every hospital every maternity hospital.
I think they're important targets for us to hold, and I know that the work of a maternity consumer rep is a really important one. I just wanted to reflect too that the fear stuff meets the system's needs, and the courageous talk meets women's needs, and unfortunately the system's needs always come first. I just wanted to reflect too, when just before we started, Rhonda was reflecting on the birth of her son 50 years ago. I count myself as a maternity consumer rep. I aged myself for my daughter's birth. She's 22 now, and I also remember that. And my first volunteer role was editing the Birthplace magazine to try and draw together, positive birth stories. And I just think this work is so important. And as somebody who's really doing so much work in this space, Lesley Pazcuzzi, you're the Lamaze Australia representative, and you've done so much work, around Fiona Stanley Hospital's one of those projects that you've been really involved in. And so I guess I just wanted to bring you into the conversation. I don't know if you wanted to start with, if you wanted to give a bit of a response to that last question around midwifery, access to services not being a postcode lottery, or whether you wanted to talk a bit more about, some of your experiences as a consumer rep.
Sure. Thanks, Pip. It's really great to be here. You can hear me okay? Yeah, I'm also on Wajak Budja land, and I wanted, on behalf of Lamaze Australia, to pay respects to the elders past, present and emerging. Anyone who doesn't know me, I'm a Lamaze childbirth educator since 2017, and I work in a voluntary capacity on the Lamaze Australia Bear programme. So we have a couple of state representatives across the country. And our job is kind of to fly the flag for the consumer-led bear program that we have. This is a relatively new initiative, only kind of 2 years old, but we, I suppose, are so really grateful for the opportunity to be part of this conversation, because this idea today on World Patient Safety Day about, acting now for safe and respectful childbirth, I think, just to answer your question there about continuity of care, we don't have to look too deep into the research to know this is the gold standard. And if we had the magic wand, it's the service we would give to everyone. I think at the moment, from a consumer point of view, COVID has really taken our women, into a space that's, not been their preferred. It's not been what they've foreseen to happen to them. But, from the to answer the question about, the MGPs, I think we're really starting to see our consumers birthing potentially in a kind of trauma-informed space. The women who've birthed now with their first child, for example, during this pandemic, they're now experiences of second and third pregnancies. Where they're starting from, we could say, is going to be informed by some degree of trauma, whether they had, no family able to visit from the interstate or from internationally, whether they had, changed access to education, or they had, restrictions on, visitors to the hospital. I mean, the list goes on. I know Jessie's going to talk a wee bit about her campaign as well, so I'm not going to go into that too much, but from an education point of view, I think what Kate said is really important, that we, whilst we can't maybe fix quickly this larger issue of continuity of care, I think there is a real, there is real work we can do if we focus in on what education opportunities our birthing families are having access to. You can do some great work by telehealth, as Kate said. There's a lot of research. I mean, I've got some here from my university that I'm studying right now. You don't have to look far to find the satisfaction results through research with telehealth. But I think when it comes to continuity of care and actually looking at what the outcomes, what do women and their families get from that? It's a feeling of safety, a feeling of security, a feeling of confidence and knowledge from knowing someone through the duration of your pregnancy. But those experiences, I do believe people can get from, evidence-based education that gives them a wealth of information that they make their choices from an informed place, and therefore however their birth unfolds, they've got a plethora of information, skills, techniques to manage the outcomes, and therefore you could have every intervention possible but still come out of it feeling positive and feeling safe and feeling listened to, because you've learned how to build your expectation but also to advocate for yourself. So whilst I'll always fly the flag for continuity of care, I do also want to fly the flag for equity of access to evidence-based education, because I know from conversations that I'm currently having with, senior midwives in the healthcare system, sometimes education is led by the person delivering it. So what does that educator think people need to know? And sometimes within the systems, in the public sector, for sure, some of the education is policy driven. It's what the hospital needs to tell the people, so that if something goes wrong, well, we told them, blah, blah, blah. And I think for me in the BEAR program, I'm always going to advocate for, getting to a point perhaps where we look at interprofessional work and we look at bringing educators with evidence-based knowledge and training in to the hospitals, and actually freeing up the workload of these midwives, because they're so stretched on the floor. The education sessions are being, really, shrunken in, because we've got a pressure on staffing and facilities that, let's not forget that we've got independent people out in the community, maybe offering private opportunities, but if we could move and evolve our health service to look at where we can bring professionals together and look at where there's success stories, we could address this issue of equity. That doesn't matter where you live or where you work or how much money you have, you can access a continuity of healthcare that actually means that everyone, whether you're in a same-sex marriage, you're a transgender person having a baby, you're Indigenous, you're a single mum, you're a surrogate family, everyone has the same access. And that comes from an evidence base that we know is going to provide someone with a positive outcome. So that's my answer to your continuity question, Pip. A bit long-winded.
No, that's lovely. Thank you for that. And I guess I'm also really interested in the work, you actually posed a question about, because Rosie had mentioned something about that, I've been having a look at review of services, and your question was, were women involved in that? And I know that you've been doing some work with Fiona Stanley Hospital's Family Birth Centre. I just want to acknowledge that Kylie Eakin is also online, and we certainly wouldn't have that at all if it hadn't been for Kylie's campaigning.
No. No, we wouldn't. And, Kylie's a great example of someone who, like Jessie, like many of the women here, when we've gone down the road of, trying to fall pregnant, we've had a pregnancy, we've had a birth experience. Often it's something that happened on that journey that gives us the motivation to do this in a volunteer space. Like, I want to really fly that flag as well. Like, this conversation today, this is voluntary for people like myself. We're not paid to put in our energy and our time. So when it comes to the consumer engagement as a whole, I think it's important to note that happens on a lot of levels. So at Fiona Stanley, we were lucky. Kylie and I worked initially in a consumer rep capacity on service design. So that was a great chance to have interactions with the management there about what would a birthing centre look like if we had, a blank canvas, and what, equipment might be useful to someone, because we obviously had birthed in the recent past compared to the staff there were, maybe their children were 20 odd years old. So we brought kind of fresh eyes, if you want to look at it that way. But, within Lamaze Australia, our vision of consumer engagement is a wee bit more than that. So it's not just about being able to provide people with the chance to, give notifications, as Karen mentioned, when things haven't gone to plan, to expectations. Yes, we can consult consumers about service design, but I think there's another piece of the jigsaw missing, and that's where consumers actually become part of how all of that changes things going forward. I think in WA, and I can only speak about WA, I haven't had experience in this capacity outside of our state, but we seem quite good at gathering information, and we seem quite good at having, consumer councils in place. So to my knowledge, they are quite common, but there seems to be a big gap then between what we do with all that information, that consumer voice, that actually makes system level change. And I feel like we almost need another pathway that gets someone a wee bit higher up the tree, because that person can't be someone who's a healthcare professional, can't be someone who's a midwife necessarily, because you lose the independent voice.
Yes.
And if you really are true to these quality improvement standards that, we are all governed by, as Karen said, the consumer is the expert. They're the person. And, another hat that I wear is in perinatal mental health. I'm just 6 weeks away from finishing a postgrad in that area. And what that whole world is looking like right now is, person-centered or, woman-centered care. Lived experience, you're not going to find anything richer in how you evolve and you move forward. So, I've got many notes written down here. I could answer a lot of the points that other people have raised here, but, I think what it comes down to for me is, you look at people's expectations of labour and birth or pregnancy care. You look at the good steps forward that Kate and her team have made out in the country. You look at the intervention rates, you look at how high our caesarean section rate is compared to what the World Health Organization would say is acceptable for our population. And for me, the link or the glue that brings all that together is education. It is our provision of what people need. And how do we set people up to succeed? Because I feel like there's a level of, we'll tell you what we need to tell you. But like Rosie said about the feedback from Bustleton, sometimes what we're filling a day with information and we think we've provided something, but people are coming out of it with gaps. And therefore, for me, I think I would encourage anyone who's listening, if they have a passion for representing mothers or representing fathers, get in touch with your local hospital or look up this Lamaze Australia Bear program online, because the more people that want to have a voice and want to work in that space, yes, it's tough going because often it's voluntary at the start, but we can then be a voice that helps to shape the decisions going forward. So whilst people want to make classes more cost effective, or they want to get more bums on seats, so to speak, being a consumer voice and being able to say, well, let's ask the people, like, what would work? What do you want to know about? Do you want to know about comfort measures? I mean, I talked to a lot of people with needle phobias. They don't want to have to think about the epidural, but social media has convinced them that birth happens best when we don't feel anything. So then they're caught in this kind of between a rock and a hard place. I don't want to have needles near my body, but I also don't want to suffer. And for me, I just don't think anyone should suffer through childbirth. This has the potential to be such a transformative moment in life. And, Rhonda spoke so beautifully about this Mothers Rising, the definition of their research centre. And I think, like Kate said, by the time I retire and by the time my daughter goes on to have her children, I'd love to think that our voice, and as much as we like to talk and we like to talk loudly about it, that it will evolve some change, and we can see, in 20 years from now that we are better than we are right now.
Oh, Lesley, I'm sitting here, as somebody that ran Community Midwifery WA for a while, which was, an incorporated organisation that provided childbirth education and was defunded.
Yeah.
And thinking about my daughter's choices, I don't believe they're that much more expanded than they were 22 years ago. We still have work to do. And I think maybe we'll rename this Mothers Rising.
I think we should. Because if we can get birth right, Hannah Dallin, one of the major researchers from Sydney, she often talks about if we can get birth right, then we're going to solve a lot of problems. Because if we can do this well, we set up these, future generations to be raised by, parents who feel successful, they feel able, they feel like they've done what they're meant to do, and that is to birth. And somehow we've lost that. So yeah, we'll keep on going, but it's to come back to what you said, putting consumers in the heart of what's happening. I think Fiona Stanley initially had a really good momentum, and we had some really positive months there, and we felt really involved, and Kylie's motivation for pestering the minister to get that happening, it was the heart and soul of that project. I think at the moment, COVID and how stretched the maternity service is, I wouldn't say the experience as a consumer rep committee in there has got the same momentum right now. I think we're all being sucked into this kind of vacuum of everyone is stretched, and it's hard to be effective in that environment right now. But we won't stop trying to do something as much as we can within the parameters that we've got.
Absolutely. I think, there's so much in that. Thank you so much for that, Lesley. And I think about Mothers Rising, and that makes me just think about our next and final, and by no means last, Jessie McGarry. So talk about women rising. So you did a lot of work around the Make It Make Sense campaign to support birthing women to have more than one support person during COVID lockdowns. And obviously you're someone too that's you're on the socials. You're the peeps that we're trying to do things like the My Baby WA. Kate and I, we don't have any skin in the game personally of having any more babies, except for our children will have babies. But it's so important to see both, Lesley and Jessie, what the work that you're doing, and I know we've talked about Kylie, the work that you've done and are doing. So I just wanted to ask you, Jessie, a bit more about the Make It Make Sense campaign and some of your takes, any of your takes on all of the above that we've talked about.
Yes, the Make It Make Sense campaign, we're still having really important conversations with people. The unfortunate thing about the campaign is it really only gets the legs behind it when it's happening, which obviously the goal is that we're preventing things. So if there is another future lockdown, we're not going to be all up in arms then, where we really can't affect change, because although our voices are loud, there isn't much that we can really do at that point. But we have made some headway, which has been amazing. So in the almost a minute now. So then the first lockdown this year, we saw a lot of, just about all of them. There's a lot of disparity between the hospitals as well, which was quite confusing. But we saw a lot of the hospitals essentially saying, once you've had your baby and you go to the ward, your partner's gone, and you won't be seeing your partner or the other parent again until you leave the hospital. And they can't come in and get you from the hospital. It's once you're actually physically outside of the hospital doors and you've taken your baby and your bags out. So that obviously we understand what that means for women when they're feeling unsupported, especially in those days. My kids have been so quiet this whole time.
They have, I know.
Now they're going to be like, oh my God, but we'll see how they go. So the main thing that we were advocating for, and I've been having some really good conversations with one of the really amazing I suppose important midwives at King Eddie's. We've been having lots of discussions. She kind of helped me figure out, we definitely want them to have more support people in birth, but we really need to focus on them getting the support around them with the other parent or partner or husband or dad or whoever in that immediate postpartum stage, which is what they were being denied of. So that's where we really drove our focus. And the way that we did that was by sharing stories. I've got over, I think, 30 pages of stories from women emailing me in from their experience during COVID and how they felt after their birth, from what they experienced during their birth and also in postpartum, because it also meant whilst partners were being excluded from supporting the women on the postnatal ward, they were also being excluded from entering the hospital doors unless the woman was in active labour. So as we know, you can still walk through the hospital doors and need to be admitted even though you may not be in active labour, which saw a lot of women labouring by themselves in a room, but they weren't, they hadn't ticked that, oh, you're in active labour now mark, which again, policy driven meant that they couldn't be supported. We were seeing a lot of partners being kicked out, some as soon as 15 minutes after their partner had a cesarean section. And so they got to have a 15-minute snuggle and then they were gone, and then they didn't see each other again for a couple of days. And we're also seeing a lot of women, because of that, discharging themselves early because they're choosing that emotional support over the physical support and recovery, which I think is a really hard choice to make for women, and they're being put in that position. So with all of those stories that we were sharing, we got invited to Parliament House by Libby Medham. You were there, Pip, and we got to have an amazing press conference, and then they did a terrible job at broadcasting that and called us protesters, even though we were invited there. Had to shrug that one off. But we did get to have some important conversations, and we had a lot of women come and support us there too with their babies as well. We're in the newspaper, the news, and then the most recent lockdown that we had, I was ready to like fire up and get going, and then I saw that they were putting no restrictions at all on partners going into support in the postnatal period and going to the wards, which was amazing. If they didn't even get it wasn't even like a 2-hour thing. They had from like 8 to 8 to go. They could go and settle them on the ward if it was in the middle of the night. They could go with them and settle them on the ward, and then they could come back in visiting hours. So we had a win. We had a win.
Oh, that's very exciting. Lots of, and I think it's that idea too. I think it's the mothers rising, isn't it? It's like sometimes sometimes we don't complain enough.
and this was a testament. It was the more voices we had and the louder it went. I didn't realize, but it was reaching other states. It was hitting other states, and other states were sharing things and supporting us and making our voice louder and louder and louder. And that's what we said. We had to unite our voices and be loud, because that's how we make a difference. And it was really good to have that testament to that, to say, well, look what we did, guys. Like when we got really loud and we shared and we shared and we shared and we spoke up and we did it all together, this is what we get. We got something. Even though they didn't really acknowledge us and say it was because of that, we're claiming it. And we did it. And I think you can translate that into everything that we're talking about here today. And like you were saying, Lesley, with it, the consumer needing to be in there as well, and the co-design and all of that, it's women need to speak up too. Birthing people need to speak up and take that responsibility as taking charge of their experience. You don't have to be in control of it, but you can be in charge of it. And I think that's the important thing, because there's this whole idea that if you're in control, then that's a silly thing because nothing goes to plan. But you can always be in charge, no matter where your birth is going and what pathway it's taking. And I think women need to have that power. They need to be reminded of that power and given that power back to them as well, and then they can take it. And then, as you've seen with the Make It Make Sense campaign, the power of our voice really does make a difference and really can elicit change.
Very inspiring. I actually had a question here come through from Bridget around the eastern states. So obviously things are in a very different position over there, and she was wondering if you had a sense of what's happening around visiting opportunities in the eastern states for birthing women.
Yeah, I've been keeping an eye on Life and Lens Photography. For anyone who's on Instagram, Life and Lens Photography, she's like really taking care of things over there, and she's got the hashtag End Birth Restrictions. She's awesome, and she's seeing a lot of change over there. From what it looks like, it's just, for lack of a better term, a mess. It's very some hospitals say one thing, other hospitals say something else. Women are getting told to have tests every 72 hours, COVID tests every 72 hours. And if they don't have one and they're admitted, then they'll be treated as potentially positive. And then there's all of these things. But I think the biggest thing to highlight is the misinformation, and that there is no regulation or overview of how these rules are being in place, which is what, that just keeps begging the question. So what's really necessary if someone can do that and someone can do that and someone can do that? So that's the sense that I've been getting from it. Some people have 2 support people allowed, no restrictions with partners, and then other people are experiencing similar to what we had, where partners aren't allowed in until there's someone in active labour, and then they're not visiting the ward at all, or they're visiting on the ward is very restricted to 2 hours. So it's everywhere, all over the place.
It's a really interesting point you raise. It's certainly something that we have discussed with the Australian Commission on Safety and Quality in Healthcare. And again, Karen, the work that you're, I think, really trying to be part of, which is to bring a bit more unified view around, how do we get some consistency, because there isn't really any one place where you can say this is the deal, because everything's done, hospitals are done state by state and territory by territory. You get this disparity.
In the conversations that we were having, we would, we'd speak to the hospitals and they'd be like, well, it's the government directives. And then we speak to the government and they're like, yeah, well, it's the hospitals choosing to do what they want. And so we're like, so who's the one calling the shots? Because it just seems like you sort of possibly are picking and choosing who's responsible, who's not. And that was like one thing I really drilled down on, was like finding who is the people, the person, the group, whoever, who is the one that I need to speak to. And someone will always say something else. Oh, well, I've sent your letter to this person, or to this organization. I've sent your letter to this person. I've forwarded it to this person. Or like, don't even come to me because I have nothing to do with this. It's somebody else. And so that's one of the things, is it's just, I still am not entirely sure who it is that calls the shots, besides if I somehow manage to like sit down and have a chat with Mark McGarry, which I highly doubt is going to happen. That would be wonderful, to just be like, hey, I need to ask you this question. Can we please figure this out? But the other thing that was really interesting is the disparity that was between, at first it was quite an initial disparity between private and public. So private hospitals didn't face any restrictions whatsoever. I'll fix it really soon. Okay. Hey, Dad. Hey, mate. Okay. The one time.
always.
I'll fix it. Hang on, let Mummy just finish talking and then I'll fix it. One of the really interesting disparities was that that's not going to work, was that the private hospitals during the lockdown, where the public ones weren't allowing partners in, is that the private would, and there was no issue, there was no restriction, there was no rules, partners could come and go. And then we started seeing that in the public hospitals, some would say yes and some would say no. And then also, as we stepped down from the changes, how we there was a post-lockdown period as well. And some hospitals, including like public hospitals, even sort of within the same health services as well, some would say, oh, yep, you're allowed to have 2 support people. And other people like, no, you can't have 2 support people. And it was just the confusion everywhere.
Yeah.
Hello.
Hello. So I'm just conscious that we are actually just coming up to time.
Yep.
And so I just wanted, I don't know about others on this call, but I feel like this is the beginning of something. It feels like it's been a great conversation. To have World Patient Safety Day as a catalyst to have this conversation has been, I think, really valuable. I know Kylie, Ekin and I do talk, never as much as we'd like, but we try and talk as regularly as we can. And we've talked a lot about the idea of, we do need to have a, like some kind of a conversation across our state around maternity. Are you still online, Kylie? I'm just wondering if you're there.
Yep, I'm here.
Can we put us, there she is. Hi, Kylie. Yeah, so I feel like in many ways this could be an important beginning of a conversation. I also wanted to flag that Julie Armstrong from the Minister for Health's office specifically is interested in having a look at the recording of this, so we'll make sure that this is available to her. I feel like there's a lot of different things that I've heard, obviously around access to models of care consistently, and targets, thinking, like I think I heard something like what would you call it, a benchmark. Did I hear 7% or something like that? Was that what you said, Kate?
That was the snapshot audit of what? Snapshot
audit, yeah.
Women that are currently accessing. I don't know what the benchmark. I think it should be 100%. But
I think it should be 100% too. But at least we have some sort of sense of where are we now, and can we create can, you know, mothers rise up and ask for the target that we want and see that through? I feel like that's the question from today.
You mentioned Julie, Pip, and I really do think that Julie is a champion in this space herself. She really is a massive spokesperson for all women. And I think a big area that we need to focus on is data collection and making data more transparent across the state. I feel like each health service is very protective of their own data, and it needs to be made public so we can see those improvements in numbers.
I love that idea, and I am conscious of people's time. We have already gone 2 minutes over. I just wanted to say thank you, Kylie, for popping in and saying, you know, and having a conversation, and also all the work you've done for women, and I know we'll continue to do. I'd also like to thank Lesley. I'd like to thank Kate. I'd like to thank Karen. I'd like to thank Rosie. I know Rhonda's already gone, and Jessie also. I'm not sure if you're still there or you've had to go off and do some parenting. We've all been there. I wanted to thank everybody online. So I know that there's a lot of people, you know, like Tracy Martin, that have been doing so much work in this over the generations. And I feel like, watch this space, because I think we need to do something else in this really important thing of, you know, working title, Mothers Rising. So thanks again, everyone, for your time today. Thanks, panelists and people who have turned up. And also just, you know, here's to International Patient Safety Day and the importance of birth and the next generation. So thanks, everyone. We'll send out an email with that info and links from some of the stuff that's come through the chat.